Hello, my name is Jeff Schoenig. I'm a registered nurse and clinical care coordinator here at St. Peter's Hospital in Albany, New York. I'll be introducing you to the joint replacement program as you are a potential patient for hip or knee replacement surgery. But first, we'd like to show you some videos. We'll give you a schematic overview of the total joint replacement procedure. These videos were created by the American Academy of Orthopedic Surgeons, one of the more well-known orthopedic organizations.
Total hip arthroplasty, also called total hip replacement, begins with an incision to allow access to the bones of the hip joint. The next step is to remove damaged cartilage and bone from the acetabulum, the cup-shaped hollow in the pelvic bone. This damage results from the bones rubbing directly against each other when protective cartilage wears away. A tool called a reamer is used to prepare the acetabulum to receive the socket portion of the hip replacement. This metal and plastic combination is called the acetabular component and is fitted into the newly reamed bone surface. The outer metal part of this component, sometimes called a cup, fits directly into the socket. The inner plastic portion has a hollow to hold the replacement for the ball-shaped bone at the top of the thigh bone or femur. The outer metal part is rough to help bone grow into its surface over time to lock the artificial socket in place. The next step is removing the ball-shaped head of the femur or thigh bone and preparing the femur for placement of the stem portion of the component. A metal ball is attached to the end of the stem and fits into the artificial socket in the hip bone. Together, these components replace the natural ball and socket joint. During and after surgery, the surgeon verifies the correct fit and range of motion of the hip replacement components. By mimicking the anatomy and functioning of the natural hip joint, hip replacement can reduce pain and permit a return to many activities. Total knee arthroplasty or replacement is a surgical procedure in which a diseased or damaged knee joint is replaced with an artificial joint. Your knee is made up of the lower end of your thigh bone or femur, the upper end of the shin bone or tibia, and the kneecap or patella. Most replacement joints consist of a metal femoral component, a plastic tibial component held in a metal tray, and a plastic patellar component. The procedure begins with an incision on the front of the knee, and the kneecap is moved to the side. Damaged bone and cartilage at the end of the femur are cut away, and the bone is measured and cut to fit into the femoral component, which is then attached. Next, damaged bone and cartilage at the top of the tibia are cut away, and the bone is measured and cut to fit into the tibial component. A metal tray is fit against the flat-cut top of the bone with its stem inserted into the bone. A plastic insert is snapped into the tibial tray. The femoral component slides on it when the knee is bent. The damaged portion of the kneecap may be replaced by a mushroom-shaped prosthesis. The resectioned patella and prosthesis are attached to other components. Measurements and tests to ensure balance and movement are done during and after surgery. Knee replacement can significantly reduce pain and improve function. Like all surgery, there are associated risks. Physical therapy and realistic expectations are important for successful recovery.
Our objectives for today here in this presentation is how to prepare for surgery, what to expect on the day of surgery, what to expect during your hospital stay here at St. Peter's, the very important roles that physical and occupational therapy play in your postoperative care, as well as discharge planning and what to do once you are home. In this era of COVID, there are different protocols you and your family will have to follow. We will talk about these at the end of this video. I'd like to talk with you about preparing for your surgery for your upcoming hip and knee replacement. Turning to the slide with the guidebook, we provide each patient with a guidebook particular to your individual surgery, which is either the hip or the knee. We ask you to please read this book. Even if you're not a reader, it was very pertinent to what you're going to be going through with your impending surgery. It'll give you a very good idea on how to prepare for your surgery, as well as what to expect while you're here at St. Peter's during your short time here with us. It helps you to be fully informed, and we find that a fully informed, educated patient has a much better experience than if you come in without any anticipation of or any idea of what comes next or the reason why we do things. So it'll help you a good deal, and it will certainly improve your experience. Please read the book and hold on to the book up to a year after your surgery. It's a good reference. It's a good question and answer guide as well. We'd like you to bring that book with you whenever you have an appointment with your primary care physician prior to your surgery, or when you come for your blood draws or any other specialist visits that you may have. It is a good reference. It can answer any questions that you might have or your doctor may have as well. So please read the book. You'll have a much better experience for it. On this slide here, on things to do before surgery, this is on a page that's found in your guidebook. That's either on page 47 or 49 in your guidebook. It depends on whatever issue you have. So on page 47 or 49 in your guidebook, you have this little checklist that we provide you. And these are the items that we ask you to keep in mind and things to do prior to your surgery. You'll notice in the far upper left column where it says 2 to 4 weeks before with the red arrow, first line item says select your coach or caregiver. This is a person that we'll talk about a little bit more in our presentation. That will be a person that is going to assist you at home and to be with you and to maybe be educated as well as you go through your event here with your surgery. In the middle column here, 1 week before, we ask you to stop shaving below the neck, no outdoor work. Now, why would we ask you to do that? Well, it turns out that you're at high risk for infection with this kind of a surgery. Wherever you remove the bone, you also remove the body's ability to fight off infection, especially during your initial healing process after your surgery. So while you're healing initially, we don't want to have any sources of infection to develop around your body. So the reason being is we want you to stop shaving below the neckline, because if you happen to cut yourself with a razor, the razor you have isn't necessarily sterile. What do you do with it after you use it? Most people place it into a drawer in the bathroom or around the sink or in a medicine cabinet that's in the bathroom. That's not a very sterile environment. If you notice, it's usually pretty hot and humid in the bathroom. Each time a person uses the shower, they increase the humidity in the area. And it's not quite like the surgical instruments we use in St. Peter's, where we put things into an autoclave. We put it under pressure, high temperature, to try to kill off any bacteria and make sure our instruments are sterile. So we ask you to stop shaving because if you cut yourself with that razor that you took out of the medicine cabinet, chances are you might create a little source of infection. And as it heals, the body does a wonderful job of healing. And it takes a little bit of time, but what we don't want to do is for you to maybe transfer the cut area where you put your hand over it or put a Band-Aid over it where you touch the area, and then to touch your post-surgical area as well on your hip or your knee. No outdoor work, pretty much the same idea there. If you're working outside, cutting the grass in short pants, and how many people do weed whacking in short pants as well? You kick up a stone or an object that cuts the skin. There's a lot of bacteria in anything that comes up off the ground. So that's the same reason. We want to be very cautious, and it's in this field of medicine, we always want to be a little bit more cautious than being less cautious when it comes to these ideas. It also says to fill in your mupirocin prescription. What that does also is whenever you breathe in, you're taking in the atmospheric oxygen and all the particulates that come with it, especially nowadays. So everything that your nose and sinuses filter out goes down into the lungs, and in the lungs we have lots of white blood cells that picks up any bacteria or viruses and takes care of anything that gets past the sinuses. But there's a nice collection that does develop inside your sinuses. So what we want to do is to reduce the likelihood of someone either moving their hands across their face and then touching their surgical area, either on their hands or their hips. either on their knees or their hips. So what we want to do is reduce that amount of bacteria that's located around the sinuses, and that's what the mupirocin does. It's a Vaseline consistency type of substance, and what you do is you apply it around the nares with your finger, follow the directions, and apply it twice a day up to 5 days prior to your surgery. And what that does, it doesn't really sterilize the area of your sinuses, but what it does is just reduces the amount of bacteria to the area. Kind of on the same principle of washing your hands. When you wash your hands, you're not necessarily sterilizing your hands, you're just reducing the amount of bacteria on your hands as well. And everything else here is pretty well self-explanatory. We just want to call your attention to the second to last column where it says the day before on the lower right-hand side. You'll notice on the very bottom of that, there's a phone number, 525-1113. And we want you to call that number a day before your surgery. The reason being is that we don't want, everybody knows the date of their surgery, but no one really knows the time of their surgery. So we want to make sure when you call up to 12, wait until 12 o'clock on the day before your surgery, call that number, 518-525-1113, and you'll get the scheduling office and they'll be able to tell you what time your surgery is and what time they want you here. With this slide for pre-admission testing, this is the part where St. Peter's gets to know the patient. Your orthopedic surgeon has called St. Peter's to schedule your surgery. Therefore, here at St. Peter's, we have an obligation to the patients. We have an obligation to keep you safe and to present to you a procedure where you can have the best possible experience given the nature of what the surgery is with replacement of your hips and your knees. So what we do is we have a department called pre-admission testing, or the PAT office, and what they do are individuals, professional nurses and support staff that give you a call or schedule an appointment to give you a call and to interview you to find out the following items such as allergies, what your past medical history is, what other surgeries have you had in the past, and anything else that might be pertinent to your health and well-being. What we do is gather this information so we can keep you safe while you're here. By knowing your allergies, we know what other medications to keep away from you and what medications we can use in order to control your pain and keep you safe. We also know about your past medical history, how sensitive you are to anesthesia or other pain medications where you might have an adverse effect. We also ask you about your use of alcohol and recreational drugs. This is very important. I'll tell you a quick story. My father, a number of years ago, had cardiac bypass surgery. And when he went through the cardiac bypass surgery, he had an interview with this pre-admission testing person, and he thought that when it came to the medications he's currently on, he thought the only things that they were interested in were the medications that were prescribed by his doctor, his prescription meds. So when he did have his cardiac bypass surgery, the surgery itself went very well, and when he went back to his room to recover, he started bleeding, and he started bleeding very, very much. He actually needed a few units of blood, and they had a whole bunch of other complications, but through the skill of the doctors, they were able to get him through. And they were wondering what was the problem with his bleeding. Well, it turns out that my father neglected to tell his pre-admission testing interviewer that he was taking an herbal supplement such as ginkgo biloba. If you notice anything about ginkgo biloba, part of what it is a very good blood thinner. And that was the reason we almost lost our father, because of that event where he omitted a certain item on his medication list. So please make sure you include your herbal supplements or anything else you might be taking, vitamins as well, and that includes recreational drugs as well. It's very important, especially with joint replacement, that we keep your pain under control. If you're taking recreational drugs, especially opioid medications, they can build up a resistance in your system where you need more of the opioid-based medications in order to keep your pain under control. If you're taking that over a long period of time, your body has built up a resistance to it, and therefore regular pain medication won't cut it for you after your hip or knee replacement surgery. So we have to do an adjustment of those medications. If we know this ahead of time, we're able to adjust your pain medications for more long-term pain medications that last a long period of time, and also stronger short-term pain medications as well. So it's very important that we get a full idea as to how you are, what you're taking at home, whether it's prescribed by the doctor or something done on a recreational basis. That includes alcohol as well. We want to keep you safe, and if we know about this ahead of time, we're able to head off any issues that may arise with withdrawal or anything else related to excess consumption of alcohol. So be accurate when you let us know about your consumption of alcohol or recreational drugs. Everything is kept confidential. You are protected by federal and state HIPAA laws as well. And also the mission of St. Peter's is to meet you at your point of need. We don't judge you, and we do everything we can to keep your medical information confidential. And you are reassured that we can keep this very private as well. Okay. Moving along here, what to bring to the hospital? Loose-fitting clothing, sneakers, and supportive footwear. We'd like you to bring light-duty stuff. Don't bring the Mayflower moving van when you come here. Most of our patients only stay about overnight in most cases. So just bring enough for your own personal hygiene, a change of clothing, and supportive footwear. We love sneakers. Sneakers are great. They fit firmly around your feet. They have good traction to lessen the likelihood of you slipping and falling. Please try to avoid the open back type shoes, and especially clogs or flip-flops especially. We don't like flip-flops. They're not very safe at all, and they're not very secure on your feet. So try to bring those items there. Bring also a photo ID, your insurance cards if you wish, and especially if you have if your case here is related to workers' compensation. That's very important information. So please bring your case number, the date of your injury, and a contact person from your insurance carrier as well. That helps us out a good deal. Just in case we need pre-authorizations for your pain medications before you go home, or any special equipment that you might need. In the next slide, we want you to remember no alcoholic beverages or smoking after 6 p.m. on the night before your surgery. Reason being is that we want you at your optimum best to be able to, for your body to be able to fight off any potential infections and to be able to heal as best as they can. So smoking can constrict your blood vessels and restrict your blood flow to the important areas, and also lessens your resistance to infection. Also, no eating and drinking gum or hard candy after midnight. We have to keep your stomach as empty as possible. That way we don't have any potential for regurgitation where anything that may come up will go into your lungs. One thing about anesthesia is that it does shut down your intestinal tract. And if you have any food in that, it won't be able to go south. It'll instead go north, and that'll be a big issue for you. Especially if you aspirate and have any of the emesis go into your lungs. Big problem for infection and post-op pneumonia as well. So please keep your stomach as empty as possible after midnight. We don't even want you chewing gum or having hard candies in your mouth, because that will also cause excess secretion of your stomach acids, which can accumulate and cause nausea and vomiting as well. So again, no eating, drinking gum or hard candy after midnight. And also, a lot of people ask the question, can I gargle and brush my teeth? Well, we have asked the experts, and you can brush your teeth, but avoid gargling, just as a precaution. Okay, on what to expect on the day of surgery. As far as parking is concerned, your back of your guidebook has specific details about parking here at St. Peter's. You have a couple of choices as to what you want to do. We do offer valet services here at St. Peter's. So when you come in on the South Manning Boulevard main entrance of St. Peter's, follow the signs towards the valet services. You'll come into the main entrance area where there's an overhang there, and you can leave your vehicle there for valet services to park your vehicle for you. They'll give you a ticket, and they're usually open very early in the morning until at least 8 p.m. at night, and they do offer you very fine services. Or you can park your vehicle yourself. There's as you come in from the South Manning Boulevard side, go around, and then you pull in to the right, follow the signs to the main parking garage, where you'll take a ticket and park your vehicle. On this slide of the day of surgery, we want you to report to ambulatory surgery. How do you get there? When you come in through the main entrance, leave your vehicle at the valet or park your vehicle in the main parking garage, come into the main entrance where they have the rotating door, and then take the elevator or staircase up one flight. That'll put you on the first floor. Follow the signs down to the H elevator or the pavilion elevator and take that to the second floor. When that elevator door opens up, you'll see a desk on the far right-hand side of the room where it says check-in, and that's what we want you to do. Go up to the desk, go up to the receptionist, and let them know who you are and what time your surgery is, and follow the instructions of the receptionist there. Anybody that's waiting in the surgical waiting area that is with you, generally it's your coach or family member, they can wait in that same area there, as it's a large waiting area with lots of seats in there. That's a surgical waiting area. We want you to stay there as a family, and usually there's a video monitor that keeps you posted as to whether the patient's still in pre-prep, in the OR, or in the recovery room. You can just follow that. Make sure you're available at all times there, as the surgeon, once the surgery is all complete, would like to come out and tell you and let you know how your loved one did during surgery. So if you have to leave the room for any reason, please be sure to let the receptionist know so they can take your telephone number, your cell phone number, or give you a pager. On this slide here, for important measures to lower the risk of infection after a total joint replacement, while you're being prepped for surgery, the nurse is also going to wash the area of surgery with chlorhexidine one last time to make sure the skin is totally clean, and we push back, reduce the amount of bacteria and risk of infection to the site. We'll also be doing a finger stick for you to measure your sugar, which enables you to be able to fight off infection when your sugar levels are within normal limits. So what we do is we take your finger stick to make sure that your sugar levels are in that good range of fighting off infection. Especially our patients who are diabetic, you can understand as well. But for patients who are not, it's just to make sure that your body is at its optimum best to fight off infection. In this slide for the operating room, I like to call your attention to the middle picture, which is the patient being prepped for surgery in the pre-prep area of the OR. A nurse is going to ask the patient questions again, just to make sure the information that you gave to the PAT nurse is accurate, and in case you need any changes to your allergies or your past medical history as well. You'll notice the patient is also in his gown, all prepped up. You'll notice by the pale section on his left wrist area that his watch was taken and secured, probably given to his coach. He has his glasses on right now, but that's going to go as well just before surgery. So make sure that when you come here for surgery, you're not wearing excessive jewelry or anything like that. If you wish to have your wedding ring in place, just let the nurse know, and they'll put tape over the area to keep it nice and secure during the process of surgery and your recovery shortly afterwards. The patient has been put into the gown, and he's meeting with the anesthesiologist prior to the procedure itself. You'll notice on the pictures on the left is Dr. Fletcher and his support team. On the right is Dr. Kangista getting ready for some knee surgery there. The surgical team itself consists of a circulation nurse. A physician assistant will be assisting as well, along with the support staff. You as a patient, as you go into the room on a stretcher, as they bring you in, you'll notice that the room itself will be very bright for obvious reasons, and that the room will be quite cool. That is usually because, first of all, nobody wants a sweaty doctor working over them, and also it's cool and dry in the OR because it helps reduce the transference of bacteria as well. So it lessens the likelihood of infection as well. But don't fear, during the course of your surgery, the OR nurse and the support staff, they periodically go to a warming oven, which is on the other side of the OR, pick out a warm blanket, and usually keep you very well covered with that while the doctor's working on your hip or your knee. You'll notice in the middle picture on the bottom where it says yes, that's an individual's knee. And I want to let you know that there's a lot of safeguards prior to the surgery starting. We want to make sure that the operation starts with the right doctor at the right time with the right patient for the right procedure. So what happens is before anything is started with surgery, the doctor goes through a whole checklist of items that identifies the patient and their condition and what is going to be done. Their whole team is working with the doctor to make sure all the information is correct and accurate. If there's any deviation at all, then everything comes to a halt and they find out why there's a discrepancy. Then they, at a certain point before they start the surgery itself, they have a timeout to give an opportunity for anybody to make any comments in case there's any discrepancies or any concerns with the team prior to the surgery. Once that check protocol is done, the doctor takes an individual pen and near the area, not on the area, but near the area, he either puts his initials on the site that's going to be operated on, or he writes yes to the area, and that's what you see in the lower middle picture there. Now, if the doctor's name is Dr. Nigel Owens, he really does not, by law, use his initials. NO just does not cut it. Also, as a patient, we ask that you don't do any type of identification on your own. We had one patient come in one time, and he might have been a trucker because on the site that he came in for surgery, he put in yes in indelible marker, and on the other limb he put no on the other knee. And likewise, another patient came in for hip surgery, and he had a bullseye done, an indelible marker on that side. So we ask that you don't leave it up to your own devices, leave it up to our own checks and balances if you don't mind, to lessen the likelihood of any mistakes being done. Okay, and on the surgery part itself, usually it only takes about an hour and 15 minutes to an hour and a half when it comes to hip or knee replacement surgery on average. Now, after surgery itself is done, then you go into the recovery room called the post-anesthesia care unit, or PACU. There, the anesthesia has stopped, but the pain control continues, of course. You'll have gradual awakening in that area as you slowly wake up. You'll have close monitoring of your vital signs to make sure everything is agreeable with your body as you recover from the surgery itself. The pain control continues throughout your stay here at St. Peter's, and especially in the recovery room. And the average duration of stay for anybody that's waiting on the outside is anywhere from 1 to 3 hours, depending on what type of anesthesia was used and how your body's reaction to it is and flushing it out of your system. Now, a big part of this surgery is the concern for pain management, and it's an obvious question to ask. To be sure, hip and knee replacement surgery does hurt. You know, we're dealing with bones. Bones are the foundation of your body. So when you're hurting on the core of your being, where the bones are, you're hurting. But there are ways that we can manage it. Joint replacement surgery itself, for our goal, is to maintain your pain level to be less than 6. So we want you to have a pain level at 5 or less. Now, why can't it be 0? Well, we could keep it at 0, but that would require a lot of opioid pain medications, and usually that runs into a lot of problems and side effects. So that's not really safe. So with our goal of keeping you safe as well, we figure that if you feel pain on a level of 5 out of 10 or less, that usually that will allow you to be able to participate in therapy, be able to walk very well as far as you can, and to be able to sleep and rest as well. When it's like a little bit more than 5, up to 10, that's the range where we want to keep your pain under control with pain medications. So please communicate as best you can with the nurse as to how you're doing at all times. We'll be asking you how your pain is and relate it on a scale of 1 to 10, with 10 being the worst pain you ever had in your life, and all the way to 0, which is no pain at all. Now, obviously, we don't want you to be experiencing pain 8, 9, or 10, so it's very important that you let us know how you're doing at all times so we can work hard to keep your pain under control at a level of 5 or less. We do use opioid pain medications. That helps a good deal, but we also use other types of medications such as nonsteroidal anti-inflammatories, which will help as well. Once you're home, and also we do this at the hospital, when we help you with your pain medication, we don't rely solely on the pain medications itself, but also ice, elevation, and mobility help as well in conjunction with your pain medication. So if you notice as we get older, we get up in the morning and we got a lot of aches and pains, but the more you move around, the more you have better pain relief and better mobility with your joints. Same idea here, even after your surgery. When you start to move after an idled position for a while in your surgical site, it does hurt quite a bit. But as you move around, slowly of course, in the beginning at least, that you're able to loosen up the joint and thus reduce your pain as well. Don't forget to use ice. Remember, we don't want you to be freezing the area, so don't keep the ice on forever. Keep it on 20 minutes on, 20 minutes off if you wish. But the ice does help in reducing pain as well, and it does work with the swelling. And elevation as well does help in the healing process to keep the leg elevated, to keep the pressure off as well periodically. It is very important that you move around as much as you can during your recovery period after joint replacement. But rest, and when your body tells you to rest, it doesn't hurt to rest for a period of time as well. All right, but it is very important for you to stay active during your recovery period as well. Remember, we have taken care of the arthritis to the area or whatever else was wrong with that joint of the knee and of the hip, and we gave you a new knee and a new hip to that area. So you're going to recover, and you're going to recover fairly quick from the surgical procedure itself. And that way you can use that new joint, that new hip or that new knee, and be able to have a better experience afterwards as a result, and greater range of motion as well. Moving over to implants and facts, the hip and knee implants, we get a lot of questions on what the materials are made of for the new knees and the new hips. Well, they're made out of titanium, cobalt, chromium, and tantalum as well. These are very durable products. They last quite a long time. They're also made out of chromatic and polyethylene, which is another word for plastic. So these materials have really improved over the years. It used to be that 10, 15 years ago, we can tell a patient that they might be able to get 10 years out of it before they needed a replacement due to wearing out of the parts. But because of the new materials that we're using nowadays, best estimates are upwards of over 30 years of longevity with these materials before they start wearing out. So once you have this done, we'll see you in another 30 years to have the replacement. We want you to let you know that most likely, in some cases, you may set off airport metal detectors as well. But we advise you to please inform the agent ahead of time, and they will most likely use a full body scanner or wand the area in addition to walking through the metal detector itself. In the section of your hospital stay, what happens after you have your surgery and you went through the recovery room, then you go up to the 6th floor of St. Peter's, where we have the Joint Replacement Center. For those of you that may be visiting, you can find the pavilion elevator. Usually you're on the 1st floor when you do access that elevator. Take it up to the 6th floor, and when the door opens up, follow the sign that you see on the right-hand side of the slide, the Joint Replacement Center, and that'll lead you into where your loved one is located. We have a professional team of nurses, technicians, and support staff that are specially trained in the field of orthopedics and can best meet the patients at their point of need. Now, there are some complications that do come from joint replacements. You can experience blood clots and pulmonary emboli. What they are is mostly after you have a joint replacement, being idle in a bed for any period of time, you may develop blood clots. So, and if any parts of the blood clot forms, wherever blood stays too long in one area, it becomes static, then that might have a tendency to clot. And what happens is once the clot forms, usually in the calf muscles where the large veins are located, little pieces of the clot may break off and circulate into the areas where they have more narrower veins. And that could be in your kidneys, your lungs, or your brain. So what we want to do is prevent the likelihood of a blood clot even forming. So what do? In the middle picture that you see, we use air compression devices. These are sleeves that are wrapped around your calf muscles for the time that you do spend in bed here and during your short stay at St. Peter's. And they're hooked up to a pneumatic pump, an air pump, at the base of the bed. And they are programmed to circulate massaging effect to your calf muscles in order to squeeze the area and keep the blood circulating away from the calves and back up into your heart where the blood is recirculated, thus reducing the likelihood of blood clots. We also use medications called anticoagulants, such as aspirin, heparin, Eliquis, or even Coumadin. Nowadays, aspirin is usually the go-to medication, less complications with that, and it works as an anticoagulant just enough where it's adequate to keep you from developing blood clots in your calves. The main reason also is what we do to prevent blood clots is mobility. You are very much encouraged to ambulate shortly after your surgery, sometimes on the same day is the goal, where we get you to at least stand at the bedside later in the day after your surgery, and even to get you to walk. And by walking, compression of the muscles during the walking process does help the blood to circulate even better, thus reducing the likelihood of blood clots. The other issue is that can form as a complication is postoperative pneumonia. That forms because of the medications we give you, such as anesthesia and the pain medications themselves. They kind of relax you quite a bit where you're not breathing as deeply as you should. And thus, your lungs become compliant and they tend to shrink a little bit with moisture that's in your lungs to settle on the bottom of the lungs, which is usually a good medium for the bacteria that you may breathe in to form and multiply at the base of your lungs. As you do that, as it progresses, the bacteria can be so numerous that it can give you a fever in the beginning stages of postoperative pneumonia. To prevent it, it's very simple. All you have to do is take a deep breath. Just breathe in deeply, slow and steady. So in the middle item there, you see a standing, it's called an incentive spirometer. That'll be at your bedside or on your table within arm's reach at all times during your stay here at St. Peter's. And basically, it's something that we ask you to use for as often as you see a commercial on TV, or you use it every 15 minutes, where you take good, long, but slow, deep breaths through that. There's a middle piston in that rises with the breath, and the nurse will instruct you on how to use it properly in order for it to be very effective with your preventing postoperative pneumonia. The other issue is because of the anesthesia and pain medication, those medications do have a tendency to slow down your bowels, and that will increase the possibility of constipation. So the best way to combat that is to increase your hydration. Make sure you stay very hydrated. Drink at least 2 to 3 liters of fluid a day, if not more. And you may use stool softeners as well, such as Colace, which is easily obtainable over the counter at your local pharmacy. St. Peter's complication rate is less than 1%. So it seems like the preventative measures that we take here at St. Peter's to keep you safe has been very effective. For the infection rates of the joint replacement program here at St. Peter's, we have a very low infection rate as it pertains to the national average. In the last 3 years, we averaged 0.68 in 2017 per patients per 100, 0.38 per 100 in 2018, and 0.37 in 2019, gradually going down. National average rates is between 8% and 1.2%. That's a pretty good average. And over to the knee replacement portion, in 2017 there was 0.24 patients receiving an infection after surgery per 100 patients. In 2018, we experienced 0.29 out of 100 per 100 patients. And in 2019, we experienced 0 patients getting an infection in their knee throughout the year of 2019. Again, national rates range between 0.8 and 1.2%. What you'll also be doing is you'll be given after your surgery, a waterproof dressing will be applied called an Aquacel. Usually your incision is covered with this Aquacel dressing, and it will be removed at your first appointment at your surgeon's office. It's a long-lasting, waterproof or water-resistant dressing itself. And what you do is you keep it on throughout your duration, your stay here at the hospital, and when you do go home. As it starts to loosen, it'll loosen on its own and eventually either fall off or be totally replaced for a dry sterile dressing when you have your follow-up appointment with your orthopedic surgeon in 2 weeks from the time you go home. The dressing itself, it has a silver core to it, which lessens the likelihood of bacterial infections, because it turns out bacteria doesn't like silver very well. We ask that you may take a shower with this and pat it dry, but don't do any immersion baths, soaking, or swimming with it during the time that you're healing with that dressing applied. We also ask throughout your stay here at St. Peter's, you might be feeling pretty good with the medications we give you, might think that you're able to do things ahead of time and be able to walk and not wait for staff to help you to the bathroom. But during your short stay here at St. Peter's, which is usually overnight in most cases, we ask that you always ask for help with the staff. Don't stand up to get yourself dressed. Don't transfer yourself from bed to chair or vice versa, or to the bathroom by yourself. Always, always have a staff member with you for that. So please make use of your call light. Press the button ahead of time before the need gets to be urgent, and just give us some time and we'll be there in good measure to help you with whatever you may need. Don't get up by yourself.
Hi there, my name is Phil Miranda. I'm one of the occupational therapists here at St. Peter's Hospital, and I'll be talking to you about occupational and physical therapy and what you can do to prepare yourself for a total joint replacement prior to having the joint replacement. I'd like to take a minute to talk about rehab, and rehab being occupational physical therapies, and also some of the things you can do to try to prepare yourself for this surgery that you're about to have. For the best results for your surgery, we tell a person basically to do several things. One of the things you can do is to prepare yourself by getting yourself stronger, work on your flexibility, and work on your endurance. So what you can do is try to work on strengthening your body. There's some exercises in guidebook section 5 that talk about different exercises you can do. I usually tell a person you can do the exercise where you have a little light pain, but all pain, I usually say all pain, no brain. A little bit of pain is not too bad if it's something that you can tolerate, and it's not too bad. So try not to put yourself through too much pain. We tell people try to strengthen your body, your arms included, because your arms will be holding onto walkers, and they're going to be needed to kind of help push you up when your leg is when you have the surgery on your leg. You'll also need to work on trying to walk a little bit more each day if possible, or 10 to 15 minutes is what we recommend. But if you can't walk 10 to 15 minutes, there's other things you can do, like you can get on an exercise bike maybe, or if you have access to a pool, you can go to a pool and try to get yourself to build up your endurance a little bit before the surgery. You can also, like I said earlier, you can work on those pre-op exercises, and we usually recommend that you try to do those exercises twice a day if possible. The exercise you can perform without too much pain, okay? You can also prepare your home. How you prepare your home, I usually tell a person, try to pick out a chair that's firm, that's hard, that's easy to get up from with armrests. The higher the chair is, a lot of times the easier it is to get up from the chair. Some of the low chairs can make it pretty difficult for a person to get up from. Next thing is think about, if you have a recliner, great. Recliners are nice because you can elevate your leg, and that's one of the things that we usually recommend is to get some elevation so that there's less swelling. So recliners are fine as long as you don't sink all the way down and you can get up and down from it. Specialty beds, I can't remember the last time I've ever ordered a specialty bed except maybe back when I worked in rehab. So we'll teach you how to get into your own bed. And we have some tricks up our sleeves. We could show you how to use maybe a cane to help lift your leg to bring it into bed, or we'll show you some other techniques so your therapist can work with you on that when you go through your therapy. We tell people, look at your home and just kind of pretend that you're going home with a walker. Will you be able to navigate through your home safely? Are there area rugs that might trip you up? If they are going to trip you up, you might want to remove them or secure them so that you can go from point A to point B safely. If you have a lot of clutter, we usually tell a person try to make the paths as clear as possible so you can maneuver with a walker. Most of our patients go home with a walker, so make sure your home is accessible. If you're the cook at home, you may want to cook some meals beforehand and freeze them so that you don't have to subject yourself to somebody else's cooking if you don't like their cooking. So you might want to have those meals prepared beforehand so that you don't have to hassle too much with meal planning once you have the surgery when you go home. And if you have pets, sometimes I had one patient who had a horse, so she needed help with her horse. And some people have dogs the sizes of a horse, so you may want to have somebody assist you with your pet. So try to think ahead with your pets and have somebody help you out as needed. And handrails and grab bars, those types of things. If you have them at home, a stair hand rail that's a little loose, we would tell you try to make sure that any grab bars or handrails are secure. We don't want you going home and then depending on it and then it breaks and you actually fall and get hurt. So we don't want that. Okay? So prepare your home before the surgery. Okay, this next slide that we're going to see has to do with the hospital after you've had the surgery, when you get to your hospital room. Your daily hospital routine will basically consist of getting up for each meal. So we encourage all our patients to be up for all their meals. I generally tell a person, if you're going to be up for your meals, it's also not a bad idea to get the person to get dressed, because the hospital gowns that we have here were invented by a guy named Seymour Bottom. So it's a good idea to have clothing that you'll be able to wear, because you will be leaving your room, possibly walking the hall, and just so that your modesty is protected. So we tell people, try to bring some loose-fitting, comfortable clothing that you would normally wear at home, so that you could actually practice dressing with the occupational therapist. Let's see. The expectation, like I said, is to be out of bed for all your meals, and therapy times will be posted on a dry erase board that you see on the slide. That dry erase board will also give you some information like who your tech is and who your nurse is. So it's good to know that. Sometimes it will have also your therapist names on the board. We try to get the schedule also posted for the following day. So that's going to be really important for your coach if they want to be present for your therapy sessions. So when you arrive in your room sometime in the afternoon, that dry erase board, they'll probably fill it out sometime in the afternoon, and that information will be posted so that you'll be able to have your coach present for your physical therapy sessions. And if you feel comfortable, you can have them present for your occupational therapy session the next day. That brings us to the slide about occupational therapy. What is occupational therapy? I'm an occupational therapist, and basically you can think about occupational therapy as the functional therapy. We work on everyday, daily activities of living, which would be things like self-care, dressing, bathing, grooming, those types of things. So we'll work with you on everyday things. After a joint replacement, it might be hard to put on your clothing. How do you get your clothing on if you have hip precautions? Or how do you put on clothing if your knee was replaced and it's hard to get down to your feet? Or how do you put on your socks and shoes? So we'll go over things like that. How do you carry things if you're using a walker when you go home? And if you're by yourself, how do you transport things from point A to point B? So we'll go over things like that. How do you get in and out of bed, like I said earlier, if you're having trouble with lifting your leg up after a surgery? We could teach you those types of things. So occupational therapy, we generally try to see a person post-op day, the day after your surgery. And the sessions are usually, it's about one session per day, and it's usually, my sessions last about 45 minutes to an hour. It varies from therapist to therapist, and patient to patient, depending on the patient's needs. And this slide is just talking about what we do, which I kind of already mentioned. We teach you dressing skills, go within precautions if you have precautions. Not everybody has precautions. Complete toilet hygiene task, household mobility, use adaptive equipment. And the adaptive equipment might be temporary, or for some people, they might really need adaptive equipment that they're going to use for a long period of time. So we'll go over how do you put on your shoes using a long shoehorn, or we might go over getting dressed using a reacher. Let me show you some common items that sometimes we recommend to patients. In some cases, we might recommend a reacher, a sock aid for putting on socks, or maybe a long shoehorn, or a raised toilet seat. You see a picture of the raised toilet seat, and you have those armrests. That's a safety frame, so that's easier to get up and down from the toilet, which is a lot of times a very low seat. So that can be a little hard for a lot of people getting up and down. We want to make sure you're safe when you do these things. And leg lifter. We can improvise using a cane, turn it around to help lift your leg. But there is something called a leg lifter, which you can use to lift your leg up and into the bed, or into a car, or into the bathtub. And we'll talk about, when your therapist sees you, they'll talk to you about those types of things. I'm going to be introducing you now to a physical therapist who's going to tell you a little bit about physical therapy after joint replacement. Thank you.
Hi, my name is Janice. I'm a physical therapist assistant here at St. Peter's Hospital. I do work on the joint replacement floor, so welcome. I hope that the information that Phil and I are providing you, as well as the other staff here, is helpful to you, more helpful than scary, because it's not scary. So let me talk about the physical therapy part. You may receive physical therapy on the day of your surgery. So it begins the day of the surgery or the morning after. The first time that you will be seen will be in your room at your bedside. A physical therapist will come in and do an evaluation. They'll ask a lot of questions. We want to know the environment that you're returning home to. So that, as Phil explained, some of the things that we may suggest for you to have, some things we may suggest for you to make your home safer, look at those things that look like tripping hazards now. Be mindful now what is difficult for you, because it may be a little more difficult when you get home. So we ask many questions to hopefully send you home to the safest environment. And also so that we can know, do you have no stairs or do you have 20 stairs? We will do 20 stairs with you, so that you know you can do them. We do encourage your coach to be present, somebody who can hear what we're saying, because we provide a lot of information in a short period of time. Your hospital stay is not that long, and perhaps under the influence of narcotics. So you might be a little drowsy and you might not hear everything that we have to say. It may not all absorb. It's helpful to have somebody else, once you're able to, if you are able to in these times, to have somebody present is helpful too. You are not having your coach present will not mean that physical therapy will not work with you. We will work with you. Okay. Once groups start back up, the group sessions are 1 or 2 times a day, and I say 1 or 2 depending on if you have had, let's say, you're the patient that has their PT evaluation on the same day as your surgery. So you have your surgery in the morning, you come up, PT comes in later in the afternoon, around dinner time-ish, maybe a little later. We work with you, ask you a ton of questions. The next day you will go into a group session. You may only need 1 group session. We may come in, we may get you, you may walk down the hall, do the stairs, we'll do your exercises. I'll explain in a little bit all of the things that we'll do in that group session. What often happens is, as we're walking back to the room, the patient will often say to me, do I have to come to that second session? I feel like I'm good. I want to go home. If you're safe, you're steady, we've acquired a walker for you if you need, and I'll talk about equipment in a moment. You're good to go. You do not need to have that second session. And really, more often than not, that is the case, where patients have their initial evaluation, they have 1 PT session, and they're good to go. The PT session is held in a centralized room, so we do have a big group room. You are with other patients. It's hard to say how many other patients, especially now, but it's fun. it's encouraging to be with other people who have had like surgery. It's not a competition. Patients are very encouraging to each other. It is led by the physical therapy staff. It says on the slide here, it's approximately 60 minutes, and that's pretty much from the time that we come to your room to get you to go to the group session and return to your room. It's not 60 minutes of being in that room and heavily participating in nothing but exercises. Who wants to participate in that much? Okay, perform your exercise program in a monitored setting and cryotherapy. That means we're going to give you some ice when you're done. Icing and elevating are going to be your friends while you're here and when you're home. You want to reduce the swelling that you have, especially in the knees. Knees become very swollen, very tight. It's difficult to bend your knee, and yet we're encouraging you to bend your knee. So work on elevating your leg and reducing that swelling by elevating and icing. It's going to be important, especially in the summer when there's a propensity for us to be swollen because it's so muggy. You'll want to be icing and elevating. Ambulation, transfers, stair training, and education. Those are some of the things that we will be working with you on and talking to you about. And ambulation is walking, transfers is how are you doing getting in and out of bed? How do you do getting up and down from the toilet, up and down from a chair? Are you able to do those? Do you need help? We want you and your coach to know if you need help, what are the areas that you need help in? And often, like I said, we have people who go, oh yeah, I can help mom's elbow up if she needs to help stand up. I can do that. I'll be there. Okay. Stairs, if you have them, like I said, we will do them with you so that you know you can do them and that you can do them safely. And education. So the goals of physical therapy, many of which I just mentioned, let me just run through them quickly again. The average time to meet your goals is 1 to 2 days. The things that we look for you to be able to do is get in and out of bed and a chair. And as Phil said, there is a thing called a leg lifter. Often, especially with our hip patients, it is difficult, or it can be difficult to get that leg in and out of bed. That often is more difficult than walking, getting that 200-pound leg up in the bed. We have some tricks. We will share them with you on how you can do that. And often, people are going home and they've got a significant other, a spouse, a child who's going to be staying with them that can do that. So, hey, honey, can you help me is often a good option. Walking using a walker or crutches. Most often, patients are leaving with a walker. If you do not have a walker, we will get one for you. That's one of the questions that the physical therapist will ask you when they first see you on your initial evaluation is what equipment do you have? What equipment do you use? Some patients have used crutches and prefer to use crutches. If that's you, please let us know. It's not our go-to. Usually our go-to is the walker, but sometimes patients don't want a walker. They've used crutches before. They're more comfortable with that. Please just let us know. We make no commission on what you walk out of here with, other than your safety is our concern. If you do have a walker, patients often ask, can I bring my walker in? You can. If you're more comfortable with your walker or you want to make sure that it's safe, sometimes the rubber feet on the walkers get a little ground down. If you're not sure that it's safe or it feels unstable, you want to have it checked out, yes, feel free to bring it in. Please label it with your name all over it, okay? So tape with your name all over it. Because we have walkers up on the Total Joint Center unit that are used amongst patients. We don't want yours to go missing amongst the ones that we have there. So please label anything that you bring in with your name on it. Like I said, if you don't have one, but you need one, we'll get one for you. You leave here with it. It gets paid through your insurance. Sometimes. There may be a copay, but that's in another slide how that works, okay? Stairs. Getting in and out of a car. We do not have a car on the 6th floor of the hospital. No, we don't. But we will talk to you about how to get in and out of a car, okay? Especially if you have hip precautions. I'll talk about that in a moment. Perform your exercise program. Exercises are important. They will be important when you leave here, when you leave from having had your joint replaced. You don't want that joint to tighten up. I don't know if you have been one of, we've heard horror stories of, my next door neighbor didn't do her knee exercises and now she's in a wheelchair. You don't want to be that person, Okay, so you do want to do your exercises. Many of you will be getting continuing therapy, or some of you, whether that's home PT or outpatient PT, and that's for the purpose of strengthening and keeping that joint moving, so that the scar tissue gives you the best pliability and you can move, okay? You don't get stiff and stuck. We don't want that. And follow your precautions. That pertains to if you've had a hip replacement. You may or may not have hip precautions. If you are not aware yet, if you have hip precautions, you can ask your surgeon, am I going to have hip precautions? If you're still uncertain, even after you've had surgery, because certainly we ask patients, do you know if you have hip precautions? And they say, no, I don't know. We are able to identify, because the doctors tell us to write, and they write it in the chart, if you have hip precautions or if you don't. We will go over those with you, if you have them or not. And it's pretty much surgeon based on how they approach the body to get into you to put your parts in. That's just for your hip. There's no hip precautions for knees. If you have hip precautions, I'll just identify it because it says here on the slide, depending on the type of hip precautions, you may or may not have them. They'll usually need to follow for 6 to 12 weeks and check with your surgeon to identify, and they're showing pictures. If you have hip precautions, those 3 things to avoid doing are 90 degrees flexion, or flexion beyond 90 degrees, which is like an L, so you don't want to make that L any smaller by either lifting your knee above your hip and sitting, or bending forward as this person's doing in the picture. It says adduct, that means cross your legs. Don't cross your legs, and no internal rotation or twisting your leg in. But don't stay up studying this all night. We will go over it nearly ad nauseum. You will have the information that you need. Equipment facts. Nearly all hip and knee patients, it says here, need a front wheel walker. In the picture, there's a walker that has just wheels on the front. You can borrow a walker. That's sometimes where people say, I borrowed my neighbor's, I'm not sure it's the right size, should I bring it in? Again, like I said, yes, you can. We will check it for you. If you bring it in, please label it with your name. If you don't have one, we will purchase one for you, or we'll order one for you, or you can purchase it yourself, but it's covered by insurance primarily if you have it ordered here. So you don't need to bring your equipment to the hospital. Like I said, we have walkers up on the floor for you to borrow if you need. You don't need to bring them. We'll let you borrow what we've got. Ice, as I said, ice is important. Ice is nice. What you can use, I'm sure, or I would imagine many of you are quite familiar with ice at this point. Ice cubes in a bag, gel pack, the Iceman machine, which is a circulating machine of coldness. From what I understand, it's kind of like a sleeve that goes either on your hip or on your knee. Ice goes in a machine, gets plugged in, and that circulates through a tube through that sleeve that you're wearing, and it pretty much maintains cold for a while. Frozen vegetables, perfect solution. Bag of peas, slap it on your hip, it'll last a while. Or an ice recipe, and the recipe for the ice is underneath that in a gallon bag. It tells you rubbing alcohol and 4 parts water. So it's 1 part rubbing alcohol, 2 parts water. Put it in a Ziploc bag. I suggest, because I did it, I made it because I was curious if it was going to work, put it in 2 Ziploc bags. I put it in one, and I didn't. Apparently I had a leak in it, and it was in my freezer, and it leaked, and it was nasty. Put it in 2, okay? We do suggest when you're putting ice on to please place a barrier, whether it's a towel, a pillowcase or something between you and that ice, just so you don't perhaps freeze or burn your skin. We don't want you to lose sensation in that area by leaving the ice on. Ice can be pretty cold. And elevate. As I said, elevating is important. In the picture, they show a picture of somebody lying down. They've got their knee above their hip. Knees usually 6 to 8 times a day, hips 3 to 4 times a day. It says keep your knees straight. If you look at this picture, the pillow is below the knee. It's at the calf. Please do not, knee patients, place a pillow beneath your knee. Okay, we want your leg out straight. We want your knee straight. We do not want your knee bent in a bent position, sleeping all night long, laying on the couch, Netflix and chill for 3 hours with your knee bent. Okay, I know I probably look really stern right now, but that's a very important part that we really need to emphasize. Is it feels more comfortable often for our knee patients to have their knee bent a little bit. It's something that you will want to avoid because you have the opportunity now to work on getting that leg straight so that you can walk better, you'll have better movement in that, you'll have less hamstring pain, which is behind your knee. You have the opportunity to work on that now. If you don't work on that now, you're going to lose that opportunity and you're going to be bent, walking with your knee bent, which may have been how it was before this. Okay, don't disappoint yourself. Okay, so that's why I say pillow, what we call distal to the knee, below the knee, at the calf, not under the knee joint. Please and thank you. Please keep your knees straight. It says your heel 12 to 14 inches higher than your heart, and that's again just to have it elevated to kind of have like a gutter effect, if you will, from ankle to hip, get the swelling down, and sleep with your legs flat on the bed. Please, no pillows under the knees. Thank you for your time and good luck to you.
In this slide now we're going to go into the subject of discharge planning. After your experience here at St. Peter's, you'll be going to the next level of care, which could include different things. With this slide for transition to home, you have different options available to you once you leave here at St. Peter's and go to the next level of care. If you go home, you have an option where if you have the proper discipline to be able to do your own home exercises and be able to do it adequately, the required amount of times per day, and be able to perform them correctly, you have the option of doing them by yourself if you wish. Make sure you do them in a prescribed number of times that the therapist requires, usually anywhere from 3 to 4 times per day. Stay steady, because during your healing process, it's very important you do these exercises so that as you heal, you'll give your new joint memory as to how far you want it to move, how often you want it to move, and how frequently you want it to move. It also builds up your muscles, your strength, and whatever supportive tissue around the operative site as well. So very important for you to be doing these exercises. If you do not perform these exercises, you may have complications where your joint may get stiff and may require intervention by your orthopedist, sometimes under operating conditions, to correct the issue. So your first time is always the best time. Make sure you do it correctly first time around during your recovery period and for the best results you possibly can have. The other option you have is if you're like me, where you need a little incentive to be able to do things as often as you can with physical exertion, you may want to opt for going to outpatient physical therapy in your community. Usually, especially in the Capital District and its surrounding counties, we have a lot of these physical therapy outpatient facilities available. Just get on to Google and Google them, or if you want to, you can ask the nurse or support staff, such as a clinical care coordinator, discharge planner, to be able to supply you with a list of agencies that are close by in your area where you live to be able to go to these facilities and perform your exercises. These outpatient facilities require a script, which we'll make sure you have, and they are also very well equipped with certain types of equipment that is particular to your stage of recovery and your need for your type of exercise regimen that you will need. You do require someone to be able to drive you, because you're during the early part of your recovery at home. It's strongly advisable that you should not be driving until you get clearance from your orthopedic surgeon. So make sure you have somebody available to you. These facilities also offer late evening hours as well to accommodate folks that work, to be able to provide transportation and to be able to accommodate you at most times during the day. So that's an option as well. Or if you don't have anybody available to drive you to a outpatient facility, you can require a therapist to visit you at the house. What you do is, if that's recommended by the therapist, you talk with them about what your needs are, and the therapist recommends home care. You'll meet with a clinical care coordinator, discharge planner, and they will work with you to be able to coordinate an agency in your area of where you live to be able to visit you with a therapist to do your exercises at home, anywhere from 2 to 3 times per week, to give you that support that you need for the exercises. Remember though, in between the days, either outpatient physical therapy or home physical therapy, on your off days where you don't have that therapy prescribed to you, make sure you do your own individual exercises on those in-between days. Very important as well. The other type of services offered is in case, and it's not very well done with a big portion of our patients, is that the option of rehab, inpatient rehab. Usually these are folks that is really, okay, start again. The other option that's available to you is inpatient rehab. This is offered to patients or individuals that have very little support or no support at home, or have a home structure where it's very difficult for them to be able to manage when they're home, such as patients that have a lot of stairs, maybe live in an environment that's not particularly safe, where they're totally alone, have no support in any way, or they have comorbidities or other issues in their health that needs attention. Then inpatient rehab may be prescribed. You will meet with a discharge planner, clinical care coordinator of St. Peter's, and we will get a selection of rehab facilities of your choosing in your area as to where you may want to go, and we'll do our best to get you reconciled with the facility, to be able to get a bed offer, and also to have the insurance be able to cover it as well. We'll negotiate that on your behalf in order to get you what you may need at your point of need. When you are at home, we want you to take your pain medications regularly and exactly as prescribed. Here's the key word, folks: if you are in pain. Now remember, during the surgery, we took away what was wrong with your knee or your hip, the arthritis or whatever else was the issue with your joint. And we gave you a brand new hip or a brand new knee. And you're going to be healing from the surgery itself very quickly. So during the period of your recovery where you're experiencing pain, we give you the support with pain medication throughout your time. And if you are in pain, that's when you take your pain medications as prescribed. But remember, as time goes on, you're going to be healing more and more every day. And as such, your pain level will be less and less as well. So if you're using pain as your guide, you will expect to be using less and less pain medication until you get to a point where you will not be using any pain medication at all, and you're in the latter stages of your recovery from your surgery. Also, like we said before, we want you to perform your exercise program as directed. Very important to do that in order to give that new joint the memory it needs to get the optimum use of that hip or that knee. In order to teach that hip or that knee how far you want it to move, how much you want it to move, and how often you want it to move. So exercise, you have to be very faithful with it in order to get the best possible outcome that you expect from your surgery. We also want you to follow your discharge medication list. There may be some medications that you're on a regular basis that may not agree with the new medications we give you for the short period of time that you'll be undergoing recovery at home. As such, during your discharge education that you'll have with the nurse will give you instructions based on the doctor's orders of what medications you may have to hold off on until you have your 2-week follow-up with the orthopedic surgeon. This will also be done in conjunction with your primary care physician as well. The other item is you may receive a patient survey regarding your hospital stay. This is mailed out on a random basis. If you are a person who does get this in the mail, we ask that you please take the time to fill it out and put it in the self-addressed stamped envelope that we provide, and let us know how we're doing. We always want to make sure here at St. Peter's that we're meeting our patients at their point of need. So if we're doing something really well, let us know. And if there's something that you have a suggestion on how to improve it, let us know as well, as we are listening at all times for the best service we can give you. And now let's talk about common experiences after surgery. Increased bruising and swelling. In most cases, bruising and swelling does not develop until a few days after your surgery, and usually not until after you have gone home. And it's a result of how fast you go home after these surgeries sometimes. So we want to make you aware that these type of bruises are normal after joint replacement surgery. With all the work that is done on the bone level of your body, the soft tissue sometimes picks up some trauma during the procedure. not altogether unusual. In this slide, you notice a well-healing knee surgery that is held together by staples, and the bruising, which is over on the forward part of the gentleman's calf. Usually that is something that will go away after a period of time, but in the meantime it will be unsightly. You notice the color is different from normal type of bruising that you're used to when you run into a coffee table, because this deep purple that you see here is usually bruising on a deeper level of your soft tissue. That is unsightly, like we say, but it will disappear after a normal period of time of recovery. The bruising also can extend on the inner part of your calf or up towards your thigh, as you see in these pictures here. And they usually form, like I say, 2 to 3 days after surgery. On this slide, for increased drainage, you'll see 2 different types of dressings. On the left is an Aquacel over a knee, and you'll see a Telfa dressing over on the right-hand side, over on the patient's lateral thigh. These are normal. You'll see some drainage occasionally to the area, but as long as the borders stay intact and are not leaking, you don't have any drainage leaking past the borders, leave the dressing alone, as it is normal to see. You may see some swelling to the area, quite a bit, but that is normal as well. And eventually, as your tissue heals to the area, all that swelling and drainage will start to dissipate. In this slide, for increased drainage with where it needs attention, on the left-hand side, you'll notice some of the drainage off to one side, where it also starts to leak out one end. That is where we like to have you call the orthopedic office and make arrangements to visit us so we can have the dressing changed properly. Likewise, on the left-hand side, little leakage past the area, or if the drainage is so thick that it starts to encompass the entire dressing, or if it starts to make the dressing start to swell with volume, again, give a call to the orthopedic office and make an arrangement where you can visit them and have the dressing changed and the wound inspected. When to call your orthopedic surgeon. We want you to monitor your incision and your dressing closely. Call your surgeon for increased redness, swelling, tenderness, drainage, foul odor, persistent fever above 100.4 degrees orally, and increasing pain. These could be signs of an infection. If you develop swelling, redness, pain, and or tenderness in the calf area, this could be signs of a blood clot as well. On the point of pain medications, if you need refills, call the orthopedic office during office hours. But if you find that your pain control is not adequate, that your medications are not cutting it, even though you're taking your medications on a prescribed basis as regularly as you can, then call the office right away. Talk to your orthopedic surgeon or his representative, and they'll be able to change your medication and call in a change of the medication to your local pharmacy. That way it'll be easier for you and more expeditious for you to receive the medications as well. When it comes to driving, pain medications can impair your ability to drive. So as long as you are on pain medications, avoid driving. We don't want you to have a terrible experience, or for you or for anyone else to get hurt. Usually the time it takes for you to start driving again after your joint replacement surgery is when you visit your orthopedic surgeon, which is usually 2 weeks after you go home from St. Peter's. Please discuss driving with your doctor or physician assistant at your first follow-up visit to see if you are cleared. Traveling facts: with car travel, it's recommended, if traveling a distance in a car, to stop and walk for 5 minutes every hour. If you're in a long trip, or if you have to drive to your hometown several hours away, this is strongly recommended. For airplane travel, we want you to speak to your surgeon. Most are okay with airplane travel after 6 weeks. Antibiotics for dental work. Most all surgeons will provide a prescription for antibiotics to be taken before going to the dentist for cleanings and other dental work. Your orthopedic surgeon or PA will talk to you about your follow-up appointment. Your to-do list: read and reread your guidebook. Follow the 2 to 4 week timeline, which is located on either page 47 or 49, depending on what issue you have of the guidebook. Get you and your home ready. If you have a loose carpet, fix it or remove it. Make sure you do your exercises before and after your surgery. And always eat healthy. On behalf of Ortho New York and St. Peter's Hospital, we want to thank you for choosing us for your joint replacement experience.